Professor Graff. I'm in my son's room, so I apologize. You can hear his fish tank and probably see half the stickers on his door here, but it's the easiest place to do a video. So I chose to do my video this time around on appendicitis. Just from personal experience, it was neat to research it as well because I had my appendix out in 2017 maybe, and went through it. Did not really have a medical background at that time, so it was nice to do some research on it and see what exactly was happening within my body. So appendix, it's a nice little pinky-sized organ that's attached to your large intestine, located on the lower right quadrant of your abdomen. My surgeon specifically told my dad that it is no bigger than the size of his pinky, and it has put all his kids through college. So definitely a common occurrence, and I feel like it's something very relatable. What it is it's actually the inflammation of the organ itself. The appendix, they're not 100% sure why we have one, maybe linked to some lymphatic type of things like your lymph nodes, but no one knows exactly what its purpose is, and it's okay, you obviously can live without it as well. So the appendix becomes inflamed. Why is it inflamed? It can be because of an obstruction, like lymphoid hyperplasia, infections, parasitic infections, tumors, benign or malignant. It can be feces that's built up. It can be an infection. But once the appendix is actually obstructed, it fills with mucus and it becomes extremely distended, and then it causes necrosis sometimes. So you're at a point where if it ruptures, it can lead to sepsis shock, and we need to remove it. So I did see that, sometimes the inflammation can be treated with some antibiotics, but more than likely what the treatment's going to entail is a surgical appendectomy, the removal of the organ. The clinical manifestations a client may present with this is, again, the lower right quadrant pain. Mine came on a little bit slowly. I did a workout with my sister the night before, thought I had like terrible gas from eating broccoli, and then woke up in the morning just in excruciating pain that did not let up. And I'm talking pain that was like up there with childbirth. So pain, again, pre-umbilical area, lower right quadrant. It's intensified at the McBurney's point, and it can radiate to the back as well. You may have a low-grade fever depending on if you're already having an infection issue, elevated white blood cells, anorexia, nausea, vomiting. I had a lot of nausea, a lot of vomiting. Side-lying position, so patients may present only comfortable and only getting a little bit of relief by lying on their right side in kind of a fetal-like position. It's exactly the only position that was comfortable for me the entire time. And then the diagnostic testing, what they did for me was an ultrasound, and I found in my research that that's pretty typical. They do an ultrasound, and they're looking to see if the appendix is compressible. If it's not compressible, then it's an indication that it's inflamed, and an indication that it needs to be surgically addressed. So unfortunately for me, a gunshot wound came in right before, so I waited about 14 hours, I think, down in the ER waiting for a surgery. But what I didn't know too, that I did want to discuss, is that part of it, and I'm going to come this way so you can see this part too, part of why I was miserable was because they were giving me some pain meds, but nothing that was really taking pain away. It would just keep me from screaming out. And what I learned in my research is that that's done on purpose. They don't want to alleviate the pain 100%, because a sign that the appendix has been ruptured is an immediate sensation of pain relief. So if we load a patient up with pain medicine and they're not able to tell us whether they're in pain or not in pain, we don't have a good indication of immediate rupture. It would be later caught maybe with an infection. So they give you what they can to keep you as comfortable as possible without alleviating all the pain, because they need to have that dialogue with the patient to look out for those signs of rupture. So nursing plan, again, is going to be an abdominally focused assessment, where you're looking, listening, palpating, looking for that lower right-sided quadrant pain. You're going to want to assess everything else as well, cardiac and respiratory, specifically because if the patient's going to go on to surgery, you want to make sure that those two are stable prior to that as well. Several different nursing diagnoses that can go along with this. You have obviously acute pain, risk for infection, if not infection related to the appendectomy, fluid volume deficit if the patient is vomiting and not taking in any fluids, impaired mobility, it hurt to walk, several different things that you can consider as far as, priority nursing diagnoses. The plan as it relates to an appendectomy would be to keep the patient in PO, nothing by mouth, because they're going to go into surgery and have the appendix removed. You want to administer fluids if they're ordered by the physician to prevent dehydration. Monitor for those signs of rupture. Monitor for the change in the patient's level of consciousness. Monitor for an instant sensation of pain relief. Monitor for signs of infection like an increased temperature, tachycardia, things like that. Side lying right position, that was what was most comfortable for me. And they do suggest having the patient lay like that if it does take the edge off the pain. No heat to the area, but you can put ice on the area and that may help heat. You don't want to address appendicitis with the heat because of the risk for rupture. Implementing those things, that's pretty self-explanatory, and an evaluation is just to make sure that the patient stays prepared and healthy enough for surgery. And obviously there are going to be some post-operative considerations to consider as well once the patient's out. There may be some antibiotics, it depends. The doctor may order some if he feels that it's already an infection-related issue, or if it ruptures, or prophylactically before surgery if that's the physician's normal process there. So I had to stay a few nights. Most of the time it can be kind of a quick turnaround. It is a fairly common surgery. It's up there with cholecystectomies as far as the rate of that, but you can live without it. It can cause some nasty pain in there, so hope you enjoyed it.